All right. Welcome back, everyone. Hope you had a good weekend in our warmer weather. So we're going to pick up here where we left off, thinking about pulmonary ventilation. So we're thinking about breathing. So last time we talked primarily about atmospheric pressure and our alveolar pressure. So our pressure out in the room, out in the world, our atmospheric pressure, and our alveolar pressure, which we can think of as the pressure in the lung, right? So those are the two pressures that we need to compare to figure out whether we're looking at inspiration, breathing in, versus expiration, breathing out, right? So those are the two pressures. That's the pressure difference that's driving our ventilation. Yep. So now we're going to add on our third pressure, our third lung pressure that we're thinking about. We're going to think about our intrapleural pressure. Okay. So this is the pressure inside our pleural sac. So the pleura line the chest wall, and then they loop around and line the lung itself. So our parietal pleura on the wall, our visceral pleura on the lung, right? And they're continuous with each other. It's a sealed sac, a sealed bubble. And we've got that fluid inside. We've got a little intrapleural fluid in this sac so that the two sides are stuck to each other. So we've got a little bit of fluid sticking that parietal pleura to the visceral pleura. And this is going to have a negative pressure. So you can think of that suction as that negative pressure. And this intrapleural pressure is always going to be less than our alveolar pressure. So the pressure right in that space outside the lung is always lower than the pressure inside the alveoli inside the lung. So the intrapleural pressure will vary with the phases of respiration. So what we mean there, right, is our inspiration, breathing in, and our kind of rest in between breaths, and then our expiration, breathing out. So we'll see a slight variation. And at rest, it'll be about -4. Okay? And the reason we have a negative pressure here is we've got some elasticity to the lungs and the chest wall, right? So the reason we need to stick them together with this slight amount of intrapleural fluid is that the chest wall naturally wants to kind of expand out a little bit, but the lungs want to kind of shrivel up, right? So if we let them do that, if we let them just relax without anything to kind of stick them together, we'd end up with this big space between our rib cage and our lungs. We wouldn't fill our lungs with air. So we need these opposing forces to be pulling on this intrapleural space, sticking the lung to the chest wall. So here are those pressures that we're looking at, right? So we're taking a section. We're going to have our alveolar pressure here in the alveoli. So when we zoom in, right, here's our alveolar pressure. And we see our alveolar pressure in this image is at 0. Okay. So when we have an alveolar pressure of 0, right, that means we've got a relative pressure. We set it equal to our atmospheric pressure, right? And we subtracted the atmospheric pressure away, we can imagine. But 0 means we're at equilibrium with the environment around us, right? So we're not breathing in or out. We've got a resting phase here, right? So our atmospheric pressure would be 0 at this point, but we do have another pressure, right? So that intrapleural pressure here we can see is -4, keeping those lungs right next to our chest wall here. Okay. All right. So one of the reasons it's important to be aware of this pressure is because of when things go wrong, right? So what you're looking at here, right? We're imagining you got some kind of a wound, some kind of an injury, right? So say this is a gunshot or a stabbing, something like that, right? So we've pierced through the chest wall, and we can see that we've also pierced this intrapleural sac, right? So now we don't have this sealed space with just a little bit of fluid. We've got this opening to the external environment. Okay? So when we have this opening to the external environment, like everything else, the pressures in the air and in this pleural sac, they want to come to equilibrium, right? All else being equal, we want everything to be at rest, right? So when we have this opening, we'll see that that intrapleural pressure comes to 0, right? Because our atmospheric pressure, we've also set to 0, right? And we can see at this point, our alveolar pressure is 0 as well. But we can see that when all these pressures are 0 at the same time, right, this is the size of the lung you get, right? So this is what a pneumothorax is. So pneumo is like for air, thorax for your thorax. So if you get air into this intrapleural space, into the thorax, and we lose that negative pressure that's suctioning the lung out to the chest wall, our lung is going to collapse and now we're not going to breathe very well. Okay. So it's important that we have that pressure there. Okay. Now, when we think of that pressure pulling on the lungs, a slightly more common way to think about it rather than looking at our intrapleural pressure in isolation is to look at this value called the transpulmonary pressure. So what this is it's looking at our difference between our alveolar pressure, so the pressure in the lungs, and that negative intrapleural pressure, right? So in the pleural sac there, okay? So when we're doing this, when we're subtracting these away, right, you can imagine, this could be my lung, okay? So we've got a lung here, we got a lung here. Okay. We're imagining what the pressure is just across the wall of the lung, right? Like across this tissue, right? So we're looking at that pressure difference, right? Our alveolar pressure inside the lung and that intrapleural pressure, which is in that intrapleural space. Okay. So this is what would be directly really causing the lung to change shape. By change shape, we mean get bigger or smaller, really. Primarily, we're thinking about getting bigger when we look at this transpulmonary pressure. Okay. So when we increase this difference across the wall of the lung, right, we're going to see those lungs expanding outward, getting pulled along with the chest wall. Okay. So when we're thinking about the mechanics of how we breathe, right, all these forces, right, we're looking at pressure gradients, right? So the force for the air to flow is that gradient between the alveolar pressure inside the lung and your atmospheric pressure outside the lung, right? So here we have that pressure difference. That's our delta P, right? And we do actually have to compare this difference now, right? We have to look at both values, unlike when we were looking at our cardiovascular system, right? So we actually have to calculate our difference, but we know that that atmospheric pressure doesn't change. That's going to stay constant. So we can tell when we have a relative pressure for our alveolar pressure pretty easily whether we're going to end up with an overall negative or an overall positive here on top of our equation. Okay? So this pressure difference, this pressure gradient is going to drive our flow here. Right? And it can reverse it, right? So when we flip the sign, the air moves the other way, but we could still use this equation to think about how much flow we have. Okay? So it's these alveolar pressure changes, these changes to PALV that are driving the movement of our lungs and the movement of the air in and out. Okay. So we're going to think about Boyle's law as well here. So as we think more about our mechanics of breathing, we're going to be thinking about what's the volume of our container. So we can think of like the volume of the space in your thorax. We can think about the volume of space in an alveolus, right? We're going to think about how changing the shape of your chest, right? The shape of that thorax and how much volume, how much space we have inside is going to change that alveolar pressure, right? So we're going to see, right, that as we expand the chest cavity, right, that's going to pull and that's going to create a drop in pressure, right? And then when we compress, the opposite happens, right? So when you compress something, that raises the pressure, and that's how we flip our alveolar pressure between negative and positive, and so how we flip our body between breathing in and breathing out. Later on, we'll think about a little bit about the radius, right? So we do still have a resistance on this equation here. So still going to be related to radius the same way we saw radius and resistance related to each other kind of inversely when we're thinking about blood vessels. But when we think about resistance, we'll think about like the airway radius. And that can be affected also by like how much mucus there is in there, right? Because mucus takes up space. So that's essentially a narrowed radius as well. But we're going to stay thinking about the alveoli and these lung pressures for a little longer. Okay. So we're going to do a couple practice scenarios just to make sure that we know which pressures to think about as we're thinking about inspiration, expiration, and the time between our breaths when we're at rest. So I'll give you a second to look through these 3 scenarios. So what I've given you, right, is all in relative pressures. So we have our atmospheric pressure here, top one. Then we have our alveolar pressure. And here we have our interpleural pressure. So looking at these numbers, I want you to pick for each of these scenarios, what's happening with our air movement? What's happening with our flow? Do we have air moving in, inspiration? Do we have air moving out, expiration? Or are we between breaths? Are we at rest? Right? And since we've just learned about this transpulmonary pressure concept, this distending pressure across the lung wall, we're going to be completionists, so we're going to calculate that out as well. I'll give you a minute or two to get started on these. So hopefully I made it big enough that everybody can see the numbers. But for scenario 1, we got an atmospheric pressure of 0. We got that across the board. Our alveolar pressure is 1, interpleural pressure -4. And then we'll walk through the other 2. Okay, so hopefully these are pretty easy and obvious. Once you get the hang of it, you should be able to do these in your head like that. But for right now, if you can't, don't worry about it. We'll walk through it. But the first part is going to be really simple, right? All of these are going to be simple because all we're doing for telling air movement in and out, right, we're comparing these 2 numbers. The only 2 numbers you have to think about for air movement are atmospheric pressure and alveolar pressure. And since atmospheric pressure is always 0, you could get away with just looking at that alveolar pressure, whether it's negative or positive, right? So our positive numbers are going to be high, so those are going to be breathing out. Negative numbers, breathing in. 0 means we're at rest. We don't have a pressure difference there. We don't have a delta P, so we wouldn't have any flow, right? So if we click through them, right? In this first scenario, right, we see that we have our atmospheric pressure of 0, our alveolar pressure, right? So that pressure in the lung, right? In this purple part, is where we would put it, right? That's positive. So that means we have a high-low gradient between the inside of the lung and the outside, right? So higher in here, right? Positive. Going out towards that 0, that's negative, right? So you can feel that a little bit if you breathe out, right? You can feel how you put pressure in your thorax to breathe out. You can feel the force, right? And you can feel that chest wall like kind of collapsing, right? We're making this space smaller, which means our pressure goes up in the alveoli. Okay. So that's all we need to look at to figure out, is that flow of air going in or out? In this case, out for expiration. And if we want to calculate our transpulmonary pressure, we're going to look at two different things, right? We're going to be comparing the alveolar pressure and our intrapleural pressure for that transpulmonary pressure, just subtracting our intrapleural pressure, always negative, away from that alveolar pressure. So 1 minus -4 here is basically +4, right? So we've got a transpulmonary pressure of 5. Okay. So we've got this distending force on the lung, still keeping that lung big enough for the chest wall. Okay. So for our next one, right, for our scenario 2, we had an atmospheric pressure and an alveolar pressure. They're at equilibrium, right? So no pressure difference means no flow, right? So we're at rest right now. We're between our breaths, right? We do still have an intrapleural pressure. That's not 0. If it were 0, we're looking at a pneumothorax, we're looking at a collapsed lung. So it's still negative. That's good. We want our lung to be filling the space, right? So if we calculate that transpulmonary pressure, subtracting 5 from 0, again, we get this pressure, transpulmonary pressure of 5, keeping that lung distended, keeping it big enough to fill the chest cavity. So for our final scenario, right, we've breathed out, we're at the bottom of our breath, we're at rest. Now we're breathing in, okay? So we can see that we're breathing in by comparing our atmospheric pressure and our alveolar pressure, right? So negative number means we now have a different high-low gradient, right? A reverse gradient, right? Our negative number means we now have a lower lung pressure. So air moves from higher outside to lower inside, okay? So we can tell these pretty much at a glance, that inspiration versus expiration. And we can see what's going on with the transpulmonary pressure here as well, right? So we have a negative intrapleural pressure, again, always negative, right? So if we calculate it out, subtract away -7 from -1, we get a transpulmonary pressure of 6. And so this is a little bigger. We can tell that we've got a little bit of extra force on the lung right now, getting it to expand a little extra here during inspiration. Okay. So, well, we have to compare a bunch of numbers. We have to remember what the variables mean looking at our lung pressures. Hopefully you see and you'll feel that it's not that bad, right? We're really just comparing what number is bigger than another, right? That's it. So now we're going to think about how and why that alveolar pressure is changing, right? So we're thinking about what's making this oscillate up above our atmospheric pressure when we're breathing out, what's dropping it down below when we breathe in. So to do that, we're looking at our ideal gas law, right? So we have this relationship here between a pressure, that's our P, pressure, right? A volume, that's the V. All right, so volume, that's the volume of our container. So we're thinking the size of the thorax, the size of an alveolus. And then on the right-hand side, we've got N, so that's going to be like the quantity of air. This is the number of moles of a gas. Okay. R is a constant, so we don't need to think about it. And T is temperature. We're not really going to think about that varying either, right? So mostly we're focusing on this trade-off between pressure and volume to understand how when our chest changes size, our volume, when our chest changes size, so that volume changes, that's going to vary our pressure inside the lung. That's going to change our alveolar pressure. To fully understand the full breath cycle, we will also need to take into account, right, when you breathe in, we do then end up with more air physically in the lungs, right? So the number of moles of a gas inside your lungs would vary as well, packing these little molecules tighter, right? So what we're looking at here is a container. We got a volume of 1, a pressure of 2, a volume of 2, a pressure of 1, right? So volume higher than the pressure. You can see these gas molecules are nicely spaced out, right? Relatively low pressure in this larger container. As we contract that container, so make it smaller, right? So we've compressed it, we have halved that volume, so now we're down to a volume of 1. And see, when we did that, we got the exact opposite change happening to the pressure. So we cut the volume in half, we doubled the pressure, right? And we can see that depicted here, right? How cramped all these gas molecules are now, right? So that's why we have this higher pressure. We're containing more stuff in this smaller space, or I guess in this case, the same amount of stuff in this smaller space, since we haven't changed our number of gas molecules here. But if we did, right, you can imagine that another way to end up with a slightly higher pressure, right, if you add more molecules here, even in a larger container, that would lift the pressure up a little bit as well, because we're thinking of this pressure as kind of how crowded it is in our container, essentially. Okay, so we got this trade-off between pressure and volume. And this is what's really changing that intraalveolar pressure, right? So when we see it other places, right, that's our PALV. Okay. So what's going to make a difference here is how much air is in an alveolus, right? They're these little bags of air, essentially, in the lungs. So you could have more air, you could have less air. More air, in general, more pressure. Less air, less pressure. And then the size of the alveolus itself, right? If it's really small, likely going to be at higher pressure, depending on how much gas is in there. If it's really big, right? So long as it's not filled up fully with gas, right? That's going to be a lower pressure because of this opposite relationship, this inverse relationship between pressure and volume. Okay. So what is happening when you are breathing in, right? What we see happening as the lungs expand, right? You start with an alveolus, right? With some molecules of air in here, right? So some gas. As your lung gets pulled out with the chest wall, that alveolus gets bigger, right? So bigger volume, right? And at first, as you're breathing in, right, we're going to keep those same molecules of gas in here, but we can see that they're now way more spread out, right? So this is a lower pressure, right? So we doubled the volume, so we would have actually halved the pressure here, right? So this is now our negative pressure, right? So negative something or other. So now we're going to have air pulled into the lung towards this low pressure, right? So maybe we'll just call it low, right? We dropped our pressure down. So now we have a pressure difference. So we'll start to have more gas entering the lungs here. So the opposite thing happens as your lungs recoil, right? So as you breathe out, you can feel your chest compressing, right? You can feel those ribs coming in. You can feel everything getting smaller, right? So in that case, we're going from a large alveolus, right? Because you already breathed in. But in this case, you'd expect there to be more gas in there after you finish breathing in, right? And then as we shrink that alveolus down, right, it gets really crowded in here, right? So this is going to create that higher pressure. And that's going to drive the air out of your body, right? So all of these are referring to our alveolar pressure, right? Okay. So this is what we're doing as we're driving our ventilation in and out of the lungs. Okay. So questions at this point? Okay, cool. Hope we all like breathing. That'd be great. Okay, so this is a diagram from your book showing what we just went through here, right? So we're looking at our changes in alveolar pressure here, right? And we can see it, our numerical readings there, and we can see the graph of how that's changing here, right? So those are both the same thing. We have a picture to help us imagine what's going on with those individual alveoli. And here at the bottom, we can see how much air is actually in the lungs. So we can see this breath volume here at the bottom, right? So we're looking at the beginning here of our breath cycle. We're looking at right before you breathe in, right? So right before you breathe in, you start to expand your chest, right? So you're expanding the chest, expanding those alveoli. So we see that pressure dropping below zero, right? When we got a negative number, that means our air is going to start to move in, right? So we can see that air moving in, right? And eventually enough air comes in that we get that alveolar pressure back to equilibrium with the environment, right? So once you breathe in as much air as you can, right, you are at equilibrium here with the environment in this easy breath, right? So you can see that that's the maximum breath volume as well, right? So you breathed in as much as air as you're going to breathe in this breath, okay? That means it's time to breathe out, right? So next we move into expiration. So as we move towards expiration, as we start to blow air out, we got to raise that pressure in the chest, right? So we can see these alveoli compressing, right? Pushing in, which means air gets pushed out from that higher pressure, right? So we can see how our alveolar pressure has become positive, right? Which means we've got this high-low gradient, right? And we can see that that brought our breath volume down, right? So this is why we're breathing out, right? So here we can see at the end of this, we are back to zero again with our alveolar pressure, right? So kind of different looking zero if you're looking at the pictures of the alveoli, but the same from a pressure perspective because we've got this relationship between pressure and volume and amount of gas, right? So here we're at equilibrium with the environment, but we got a small alveolus with a little bit of gas in there, ready to move into our next breath, ready to expand. That's really all we need to think about when we are thinking about how we're ventilating, how we're breathing in and out from a pressure perspective. Okay. We might want to add on what muscles can we see that are creating this change in the chest wall, right? So what physically is making your thoracic cavity larger, what physically makes it smaller. Okay. So when we breathe in, so inspiration, we've got our inspiratory muscles increasing the volume of the thoracic cavity. So those are going to be, here, I'm going to draw, this is going to be my sternum. Okay. We're going to have ribs. I'm not going to draw the right number of ribs. Okay. But we're also going to have our very important diaphragm. Okay. So our diaphragm here, when it's flat and contracted, this is the biggest your thorax gets. Okay, so big thorax looks like this. And we also have our external intercostals involved here. So you'll see those in lab if you haven't already. Those are the ones that are external, so the ones most on the outside, but you can particularly recognize them because of that fiber direction, this kind of hands in your pocket fiber direction on those external intercostals, which means that when you contract them, they pull your ribs up and out, right? So they're pulling the ribs forward and out to the side because of that fiber direction. So that's part of why we mention the fiber direction when we look at these in lab. Okay. So these are going to contract in order to make your chest cavity bigger, to make the thorax bigger. You do also have expiratory muscles, so muscles that can aid in breathing out, okay? But usually we're going to see that expiration is kind of a passive process, right? So our diaphragm in that flat state, that was contracted, right? So the smallest length of a muscle is its contracted state. So if our diaphragm relaxes, and it's not an expiratory muscle, it was an inspiratory muscle, that's why it's not listed, but its position would be something like this, right? It's going to be like a dome when it's relaxed, right? So just relaxing your diaphragm can make your chest smaller and push air out. But we also have our internal intercostals. Those fibers run the opposite direction. So if you want to forcefully breathe out, you can use those to snap your ribs tighter and smaller, right? That can force air out. And you can also use your abdominal muscles, right? So maybe we remember from when we were talking about the cardiovascular system, right? That venous return to the heart could be driven by our respiratory pump by varying pressure in the abdomen versus pressure in the thorax. Right? So we've got this trade-off between abdomen and thorax. So if you contract your abdomen, right, if you make that space smaller, you can feel it making smaller, right? It pushes up on your chest because those organs have to go somewhere, right? So that's kind of like shoving organs like your liver and your stomach and stuff into space that could otherwise be occupied by your lungs. So those are muscles we would use in forced expiration. Okay. So here they are in pretty form. So the diaphragm is the most important muscle to remember when you're thinking about pulmonary ventilation, when you're thinking about breathing, because this was the one that has the most effect. So when it's active, flattened, you breathe in. When it's relaxed, you breathe out. But we've got these other muscles assisting. So external intercostal muscles contract to assist that breathing in, that inspiration. And if you want to breathe out hard, you're going to use your abs. You're going to use your internal intercostals in addition to just relaxing. Okay. So we can see the effect that this has on the size of your chest, the size of that thoracic cavity. So here we're looking at a cross section horizontally, right? So we're like chopping ourselves in half here. So you can see those ribs expanding side to side, right? So medial laterally and anterior posteriorly, right? So forward, right? And you can feel that when you breathe in, right? You can feel your ribs move out. You can feel your sternum move up. Hard to feel your diaphragm, right? If you've been breathing really hard for a long time, you might feel something down there cramping, but we're not going to put a hand on our diaphragm really because it's separating us from our abdomen. It's kind of sitting on your liver, but we'd also see that diaphragm contracting down. And here we see in expiration, we're relaxing, chest cavity is compressing down, and we got some muscles that can help us, particularly for active expiration. Okay. So we have nerves, of course, that control this, right? We got to control those muscles, right? So we're going to have somatic nerves going to our diaphragm to help it contract, right? These are skeletal muscles, right? So this would be our typical somatic nerve with its acetylcholine that we talked about last semester. Okay? So when we want to breathe in, we send a signal down to the diaphragm, tell it to contract. So it moves flatter, moves down. We also have nerves going to those external intercostals, telling those ribs to pivot up and out. Sometimes we think of this as like, think of the like handle of a bucket as you lift it up, or like a handle of kind of like a pump if you're thinking your sternum moving up. You'll just hear that sometimes in the future, bucket handle and pump handle changes to the thorax, but the whole point is just we're changing your ribs to make this bigger, this cavity bigger. When we make this cavity bigger, the thoracic cavity volume increasing, that means we're dropping down our pressure, right? Because we got this trade-off between volume and pressure. So our interpleural pressure is dropping, our transpulmonary pressure goes up as our alveolar pressure goes down, and air moves into the lungs, into those alveoli. Okay, so we got a whole flow chart for anybody who likes flow charts from your book. right? But all we've got is those somatic motor neurons sending their neural input, right? Your brain, your breathing sensors are telling you it's time to breathe in, right? So we got our nerve sending a signal to the diaphragm and external intercostals, telling us it's time to breathe in. So diaphragm goes down, external intercostals contract, and your ribs spin out and up, which means our thoracic cavity is bigger, our chest wall has expanded, it's pulling away from where the lungs are right now, right? Which means it's pulling a little, suctioning on that intrapleural fluid in the pleural sac, right? So that would be more negative, which means we'd have a larger transpulmonary pressure to distend the lungs. So we got a force across the wall of the lung, like pulling on it to stretch it out and get it bigger. So our alveoli all get bigger because they're getting dragged, which means that their pressure drops because we're thinking about this before we've filled that new space with more air, right? So same number of gas molecules, bigger volume of this space means that we're not as crowded, less pressure. So that's when we start to see this pressure gradient between the atmospheric pressure and that alveolar pressure. So we got a bigger difference here as we have this more negative alveolar pressure, which pulls air into the alveoli towards that low pressure that we've created. Now we have gas molecules coming in. So we're starting to fill that expanded volume. And eventually this will create a negative feedback loop, right? As we pull more air into the alveoli, this is going to raise that pressure. Those gas molecules are getting kind of crowded again. So eventually we stop breathing in once we have an alveolar pressure that's equal to the atmospheric pressure again. Okay. So there are many ways that you can depict it and think about it. We've given you options, basically. But all these things are kind of telling you the same thing here, right? So we're looking just again here, saying we're paying attention to the difference, that pressure gradient between inside the lung and that alveolar pressure and the atmospheric pressure. We know we have an intrapleural pressure in the sac here that can help the lungs follow the chest wall. If we wanted to calculate from the lung wall's perspective exactly how much it's getting dragged and suctioned onto the chest wall, that's our transpulmonary pressure, all of which expands this alveolus, makes it larger during inspiration. So here we're just looking at our changing alveolar pressure, our changing intrapleural pressure, which is our lower priority pressure for this unit, but good to know it's there. Would be really bad if something went wrong with it. And we can see that difference, the transpulmonary pressure depicted here. What you might want to notice, and we'll talk about as we go through, is that with this typical easy breathing, we're really just going between an alveolar pressure of -1 at the bottom of our breath here during inspiration. And then the highest we see it going here in this easy breath as you breathe out is just +1, right? So when we look at easy breathing, these numbers are not going to be particularly big, just above and below atmospheric pressure by about 1 millimeter mercury of pressure. And all of this is what just drives you breathing in and breathing out. Okay. So breathing in takes contraction of your diaphragm. So we need neural signal for that. External intercostals are assisting. So we need innervation for that, telling both of these muscles to contract. But you don't really need a signal to tell something to relax. You're just stopping a signal. So expiration is normally a passive process, right? So when we stop signaling the diaphragm to contract, it relaxes, pushes air out. Same thing with the external intercostals, right? If they're not pulling the ribs up and out, the chest just kind of folds in a little bit. So our chest wall recoils, our lungs recoil, decreasing the volume of the thoracic cavity, pushing air out, unless you want to really forcefully breathe out like, right? So you can maybe feel that like helpful to kind of breathe, at least for me, as you think through these things. You can feel that you expend a little bit of effort maybe to breathe in, right? But if you just let go of that breath without even pushing, you'll feel the air move out a little bit, right? You can breathe out harder than that, right? If you puff air out hard, you're using those expiratory muscles, so those internal intercostals and the abdominal muscles, but you don't have to just let go of a breath that you've breathed in. Okay. So we'll start a little bit of this factors affecting pulmonary ventilation, but the real central part of this unit is just looking at that alveolar pressure and understanding what's going on with the alveolar pressure. Okay. So when you're studying, prioritize that. Prioritize thinking about what makes this alveolar pressure lower or higher. How does that change our gradient for air movement, pulling air in or pushing it out? Okay. So our brief intro here when we think about factors that are going to affect pulmonary ventilation is we're going to come back to these concepts of compliance and resistance when we come back. So we want to remember what these things are, right? So we spent a long time talking about resistance, and at least I think that resistance is a bit more intuitive of an idea, right? But remember, resistance has to do with the radius of a tube, right? So a small tube is harder to push through, more resistance. Big, wide tube, easier to push or pull through, easier to have flow, right? So that's going to affect changes in pulmonary ventilation, right? If you've had like an asthma attack or something, like you can feel how changing an airway can change how hard it is to breathe. Okay. Lung compliance, find compliance to be a slightly harder concept, at least for me to wrap my mind around. So I'm just going to tell you that I always think about those veins and arteries in this picture when I think about compliance in order to remember. Right? This is just another relationship between pressure and volume. Right? So when we're saying high compliance, low compliance, we're saying how much pressure does it take to create a higher volume, or how much does volume affect pressure, right? So something that's highly compliant is all loosey-goosey and floppy, right? Doesn't take much pressure to make this thing a lot bigger, right? So low pressure, lots of volume. If something has low compliance, we're thinking something like an artery, something with a much more elastic, thicker, maybe stiffer kind of wall to it, in which case it's going to take a lot more pressure to change the volume. And volume is going to create really high pressures, right? So we can read these graphs either way. We can think about, okay, what happens with low pressure, what happens with high pressure, or we can think about it in the reverse. What happens with a lower volume? What happens with a higher volume? Won't go too high because this lower line isn't too high. Okay. So we'll come back to this next time. Yeah, and we'll end a little early here because I think we really want to hammer home in our studying that change, that difference between our alveolar pressure, what's changing that, make sure that we only